Hello, my name is Kenny No. I am a Pharm.D student at Mercer University, and this is my presentation over a retrospective evaluation of the incidence of secondary carnitine deficiency in hospitalized adults. This is my disclosure slide, and we don't have anything to disclose at this moment. This is my poster. So what is carnitine? Carnitine is a derivative of amino acid. It's mainly found in heart and skeletal muscles, but they can also be found in liver, kidney, and plasma. They're stored about 70 times more in the muscles than the plasma. Carnitine also plays a major role in the metabolism of fatty acids into energy, and they do this by transporting fatty acids into the mitochondria for oxidation, where it's oxidized into energy. And so without carnitine, we would have a buildup of fatty acids in our liver, in our hearts, in our muscles. And so this can lead to heart problems, liver problems, as well as muscle weakness. About 75% of our carnitine is found through our diet, mainly through red meats. About 140 to 190 milligrams of carnitine is in each 100 grams of uncooked meat. The rest is synthesized in our livers and kidneys, but they require cofactors such as ascorbic acid or vitamin C, ferrous iron, and pyridoxine or vitamin B6. Two types of carnitine deficiencies are primary carnitine deficiencies and secondary carnitine deficiency. Primary carnitine deficiency is more rare. It's due to genetic mutations, while secondary carnitine deficiencies can occur due to urinary losses, medications, poor diet, or malabsorption where we're not absorbing enough carnitine in our diet. Some medications that can cause carnitine deficiency, secondary carnitine deficiency, would be valproic acid as well as Bacavir and other HIV medications due to the fact that they increase the urinary excretion of carnitine. And so secondary carnitine deficiency is often unrecognized in hospital adults. So the purpose of this study is to determine the incidence of secondary carnitine deficiency in hospitalized adults. This is a slide showing how carnitine is synthesized in the body, deriving from lysine and methionine, using cofactors, vitamin C, iron, vitamin B6, and niacin that you can see in the circles. So we did a retrospective chart review for our study. The primary objective was to evaluate the incidence of secondary carnitine deficiency in hospitalized adults, while our secondary objective was to assess other potential risk factors that could lead to development of secondary carnitine deficiency, and to assess secondary carnitine deficiency as it relates to the cofactors vitamin B6, vitamin C, and iron deficiency. Carnitine deficiency is defined as a total carnitine less than or equal to 35 micromolars per liter and or a free carnitine level of less than or equal to 25 micromolar per liter. We included patients over 18 years of age with at least one level of carnitine reported between July 1st, 2015 and June 30th, 2019. We excluded anybody who had primary carnitine deficiency, genetic carnitine deficiency disorders, pregnancy, breastfeeding, or if they supplemented with carnitine with more than 330 milligrams per day. Our data collection included demographic information, past medical history, surgical history, as well as micronutrients levels, and we used descriptive statistics for our results. 930 total patients were identified with having at least one blood carnitine level over the age of 18. 334 of those patients had secondary carnitine deficiency as defined earlier, with 45 patients being excluded from the study based off of the exclusion criteria, resulting in 289 patients enrolled in the study. The average age was 51 years of age. The average hospital length of stay was 35.1 days. The female percentage was 65.4%. The average BMI was 27 kilograms per meter squared. The incidence of secondary carnitine deficiency in hospitalized adults was 334 out of 930 patients, or 35.9%. We included all 334 patients with secondary carnitine deficiency in this number because we were looking at the incidence of secondary carnitine deficiency at Emory University Hospital, regardless if they were excluded from the rest of the study. For secondary objectives, we saw that the top 5 comorbidities were hypertension, GERD, AKI, diabetes, and hyperlipidemia, with hypertension being the most prominent, with 47.8% of patients having it. We also looked at nutritional diets. Most of the patients were on oral diets. About 72.7% of the patients were on oral diets, while some patients were on enteral nutrition and parental nutrition prior to admission. We also looked at cofactor deficiencies, such as vitamin C, iron, and vitamin B6, with 15.9% of the patients having vitamin C deficiencies, 10% having iron deficiencies, and 12.1% having vitamin B6 deficiencies. Some strains and limitations. Some strains would be large study population with few inclusion and exclusion criterias, meaning that this is easier to apply to real life situations. While limitations would be retrospective chart review, where all of our data was based off of what we could find on the charts in the past. Data collected from narrow population. All the patients in the study were from Emory University Hospital. And cofactors were not available for all patients. This is a huge one because our secondary endpoint, our secondary objective was to look at these cofactor deficiencies. Some patients could have cofactor deficiencies, but they didn't have levels drawn, so we wouldn't know they had it based off of the charts. Secondary carnitine deficiency is prominent, affecting about a third of patients at Emory University Hospital. Clinicians should consider screening for secondary carnitine deficiency due to its high prominence and it being a generally unrecognized disease state in the hospital setting. Larger prospective studies are needed to assess clinical impact of secondary carnitine deficiency in adult patients. And these are my references. Thank you.